Welcome to my webcast series, Making a Difference. I'm Dr. Stephen Grinstead. Today I want to talk about the role of recovery-friendly medication-assisted treatment for people who are suffering with chronic pain and a coexisting opioid use disorder. We need to start developing strategies for healing the whole person. One of the things I'm going to be covering today is the desperate need we have for this modality. We're still at a very interesting intersection of chronic pain and the opioid epidemic. I'm starting to see some posts saying that maybe the epidemic's over, but unfortunately, I don't believe that's true. So what I think we need to do is to understand the synergistic problem and what it takes to get into an effective synergistic treatment solution. There are a lot of obstacles for positive treatment outcomes for this population. Unfortunately, there's still a mindset in a lot of addiction treatment programs and a lot of 12-step recovery programs that have a belief, and it's a mistaken belief, that people who are on medication-assisted treatment aren't really in recovery. This is really not healthy. It's not true. As a matter of fact, SAMHSA states that patients taking medication for an opioid use disorder should be and are considered to be in recovery. There's also a lot of obstacles that contribute to the underuse, and I'll be talking more about that. I believe one of the major obstacles for people with chronic pain and coexisting disorders is the failure of their healthcare providers to recognize or treat the different coexisting disorders. So what are these? Well, there's some of the more common ones that I want to cover. And we talk about people with medication misuse, abuse, pseudo-addiction, or even addiction. A lot of the patients I've worked with over the years have had moderate to severe unresolved trauma history, like post-traumatic stress disorder. Depression is one of the most common coexisting disorders for people with chronic pain, and sometimes it doesn't get screened or treated appropriately. Anxiety disorders, social anxiety disorders, severe isolation, sleep becomes a major problem for many people suffering with chronic pain. There's a cognitive impairment that happens for people, not just because of the medication, but from living with high levels of pain day in, day out. And many people start using food to cope instead of for fuel. These are just some of the more common ones that I've seen in my practice and programs I've consulted with over the years. What is another obstacle? Well, it's that severe lack of medication-assisted treatment for these chronic pain patients that have the coexisting mental health and substance use disorders. As a matter of fact, only about a third of the people that need it will get it. That needs to change. We really need to start embracing medication-assisted treatment, but I really want to coin that with, I believe we need to embrace recovery-friendly medication-assisted treatment. So let's talk about what I mean when I say recovery-friendly medication management. And remember, this is for the chronic pain sufferer who has a coexisting opioid use disorder and probably other mental health disorders. The first criteria, recovery-friendly, basically means it needs to be a medication that won't trigger a chemical relapse. So it has to be safe. The one that SAMHSA talks about is methadone, Suboxone, and naltrexone. Those are three that, if used properly, probably won't trigger that. But there's many other medications for mental health use that need to be recovery-friendly, and stepping away from the powerful benzodiazepines like Xanax, Ativan, Valium, etc. We want to make sure that the medication we're suggesting has efficacy. It's evidence-based. And the thing a lot of the docs I work with talk about is start low and go slow. So they want to, first of all, just make one medication change at a time so they know what's doing what. They want to use genomic testing to make sure how the people metabolize on it. And then they want to start at the lowest possible dose. And then the big thing is that there's no cookie cutter here. It needs to be individualized for each person and used very strategically along with other non-pharmacological interventions, not just medication. So we need to step them away from the mindset that all they need to do is take the right pill and everything will be fine. No, there's other things they need to do also. We want to make sure that we do drug screening to make sure people are using what they're supposed to be using and not using what they're not supposed to be using. Compliance monitoring. And we want to help them find the most cost-effective medication alternatives. There's a real need for recovery-friendly MAT, and this next portion I drew from the new Tip 63 from SAMHSA that talks about the need for this medication. And it's for, healthcare, addiction professionals, policymakers, patients, families for opioid use disorder care. It talks about 3 primary medications, methadone, naltrexone, and buprenorphine, but also other strategies that are needed and services that are needed, or wraparound services for these people in recovery. There's a lot of people that have opioid use disorders. This may be a low estimate. According to the Tip 63, there's almost 2 million Americans that have an opioid use disorder related to prescription opioid pain medications. This is costing us a lot. In 2015, it was estimated over $500 billion or $500 billion rather dollars, 504 billion. It's probably higher than that now. 4 years later, I think it's closer to $750 billion. Prescription opioid overdose deaths are going up dramatically. And, there's a lot of, in 2016, the deaths were over 42,000 people. And this is more than people killed in motor vehicle accidents. The emergency department visits. Now this is where a lot of the healthcare dollars get eaten up. There's nearly doubled in this 9-year period. And hospital stays increased 64% nationally in that same 9-year period. And it's known that these opioid use disorder medications reduce the need for going out to the street for illicit opioid use. They keep people in treatment longer, give them a better chance of making successful treatment outcomes, reduce their risk of dying, and the evidence is showing it's really clearly that this is better from people that get either a placebo or no medication. Significant difference. What we really need is integrated, concurrent, targeted, and collaborative treatment, and the patient needs to be at the center of the bullseye. There's a definite need, and the World Health Organization has 9 principles of what good care for chronic diseases can guide us with our opioid use disorder care. A lot of these are really common sense. So here's the roadmap. There's 9 steps. It's develop a treatment partnership with the patients. Work with them, not on them. Focus on the patient's concerns and priorities. If we meet them where they're at, they're much more likely to follow the treatment plan, and help them self-define self-management strategies for what they're dealing with. And use the 5 A's at every single visit. The 5 A's are assess, advise, agree, assist, and arrange. And there's a lot more I can say about that, but just these 5 things can make a big difference, because This leads the patients to know they're listened to, affirmed, taken seriously, and they're much more likely to be willing to go along with a collaborative treatment plan. We want to make sure to have proactive follow-up with people. So it's not just like set them loose and go on your own now. No, it's. And then we move into link them with wraparound services, community resources, whether it be self-help support. Again, be careful because there's a lot of these self-help programs that think people are on medication, they're not really in recovery. But there's other like chronic pain support groups, Chronic Pain Anonymous. There's a new 12-step group called Medication Assisted Recovery Anonymous, which might be helpful. We need to work together as a clinical team collaboratively with the patients and involve peers, quote, expert patients. These are people that are doing the right thing, that are improving their quality of life and levels of functioning, and bring them in to help support the clinical team and the health team. And make sure there's a continuum of care. Continuing care planning needs to start at the first session. Best practice treatments include biopsychosocial spiritual interventions. We want to use only necessary biomedical interventions. Step away from the pure biomedical model and use only as needed procedures. Use as needed recovery-friendly MAT. Not every single person will need medication-assisted treatment. So guide it where it's needed. Make sure there's a heavy emphasis on dealing with the psychological clinical process, dealing with people's cognition and affect, emotional management, thinking management, etc. Make sure to expose people to non-pharmacological pain flare-up approaches. Pain flare-ups can trigger relapse episodes, so helping people find that there's things besides medication that can help them function better. Make sure that there's ongoing family and social support systems. The family members often need more treatment than the pain patients do. We want to include the biggest underutilized resource, which is the spiritual component. Many of these people have been totally cut away from their spiritual values, practices, and principles, and this can be a really untapped potential for helping patients heal. We need to deliver both individual, group, and family processes to help people be more successful. These are all the best practice treatment principles. Now, after watching this, I want to encourage you to talk about what is the most important thing you learned by going through this webcast. What are at least 4 things that you can commit to doing differently to improve your levels of functioning and quality of life? Because if you can do it for yourself, you can further aid the people you serve. What might get in your way, and how can you overcome any roadblocks? And who are 3 appropriately accountability partners that you can ask to be part of your team to make sure you continue to be more effective? So again, it's important to help make a difference. Learn about the role of recovery-friendly MAT for people with chronic pain and coexisting disorders, including substance use disorders, especially opioid use disorders, and help develop strategies for healing the whole person with strategic, individualized, and integrated treatment teams. Thank you for joining me today, and I hope you found this helpful, and I would look forward to your feedback.